Good morning, and have call the roll. And Councillor Brenner is online. Is there any declarations of interest in the agenda for today? Hearing none and seeing none, I need a mover for the adoption of the minutes for May 4th from Health and Social Services. I have a mover, Councillor Anderson, Councillor Jubb, seconded. Any opposed? We do not have any statutory public meetings. I'm going to move to presentations, and I'm going to call on Lisa McIntosh to introduce our first presentation.
Good morning, everyone. So I am very excited this morning. I gave the presentation last month, and I'm really excited to introduce our two managers within the homelessness team in social services in our income, employment, and homelessness division. So with me, I'm going to turn the mic over to Sahar Furitani and Jocelyn Siciliano, who will be giving the presentation this morning. Sahar, her portfolio is focusing on system management and working with our service providers and developing out that part of the portfolio. And Jocelyn is focused on direct delivery, our new outreach team, and the work that's happening in the community around homelessness. So thank you very much.
Your presentation's I hope so. Okay, there we go. Thank you. In this report, we will be discussing the funding for 2023-2024. Our planned improvement project plans will include improving system coordination, enhancing system and program oversight, developing street outreach programs, and enhancing our housing program opportunities. There we go. We previously presented on 2022 data overview, current forecasting, program overviews, key challenges and bright spots, and Durham Advisory Committee on Homelessness.
The Homelessness Initiatives team is now expanding to include a system management team with a focus on oversight of the system, a direct service delivery team with a focus on human-centered service delivery. Regional staff are now engaging in the direct delivery of homelessness support programming and will be able to provide a fulsome overview of the homelessness support and coordinated access system throughout Durham. During COVID, OW staff were positioned in the community hubs, in hubs and at libraries across Durham. And in 2020, we started a pilot called the Community Support Program at OW. This team took on intensive case management of a small caseload of people assigned to them from the by name list, regardless of their income source. We worked alongside the agencies with Housing First teams already doing the work, and this gave us an opportunity to identify gaps and challenges in the current system and make recommendations for improvements. It is no longer a pilot and is now called the TSP, or Transitional Support Program.
Durham Region's homelessness support and coordinated access system is funded through federal, provincial, and regional funding. Funding levels prior to the pandemic were stable but insufficient to drive reductions in homelessness. This chart includes the federal, provincial, and regional investments in homelessness over time. Prior to 2022, funding to support homelessness was below I apologize, prior to 2020, funding to support homelessness was prior to 10 million. The most of the funding was provincially driven. Funding increased in 2020 through the federal Reaching Home COVID-19 funding and the provincial Social Service Relief Fund. These funds were one-time funding to support the community respond to COVID-19 and capital projects to increase housing facilities connected to Durham's by name list. In March 2023, the province announced an additional investment of $220 million annually for homelessness prevention program and Indigenous support housing programs. The region's 2023-2024 allocation increased from over $7 million to just over $18.6 million. The regional investment to complement federal and provincial funding allocations increased from $27,000 in 2021 to over $6.2 million in 2023. This new sustained regional and provincial-based funding has significantly increased the ability to strategically plan and improve services for our homelessness programs.
So, planned allocations for 2023-2024. This graph represents the current planned funding allocations for sectors within the homelessness support system in 2023 and 2024. These allocations include placeholders for programs that are currently under development, as well as the expansion of the regionally operated direct delivery teams, including a new street outreach team. Strategic planning is ongoing. Finalizing program and system allocations will be determined within the coming months. We are working to develop and expand the system through data-driven processes that align with the recommendations set out in the Org Code report in the Council information package shared on February the 3rd.
Funding is targeted to deliver frontline services in partnership with community agencies across Durham Region. This includes preventing people from becoming homeless through eviction prevention, rental and utility arrears support, and by providing support at landlord-tenant boards. Programs to support people who are experiencing homelessness through housing-focused shelter programs, service hubs, and street outreach programs. And by providing a range of housing programs to end homelessness through transitional housing, housing first, supportive housing, and housing outreach programs. An increase in investment will provide an opportunity to make significant, well-planned, and impactful improvements to support system and achieve better outcomes for people experiencing homelessness in Durham. This will also allow the ability to develop additional support that can be provided directly by regional staff.
So the region is taking steps in 2023 to significantly expand both direct support and the oversight of homelessness support system. This includes one new management lead within the Income, Employment, and Homelessness Support Division to manage the homelessness portfolio. This is a significant increase in oversight capacity for the system. The region is increasing its capacity for oversight and coordination of funded programs, as well as improving the data integrity of the by name list. Increasing housing outflow. So a portion of the new investment in homelessness programming will increase targeted housing interventions for specific population groups of Durham's by name list. This includes 60 new housing placements that include different programs and support models to specifically target chronically homeless, high acuity by name list clients, implementing a new partnership to add 20 program spaces to support pre and post addiction treatment transitional housing, as well as post-treatment support for other transitional housing programs. Chronically homeless, low acuity by name list clients, developing a housing benefit to target people with low support needs who do not require long-term support. Chronically homeless youth by name list clients, expanding a successful Housing First model for youth to add an additional 15 placements. Veteran by name list clients, implementing a new partnership to target all veterans on the by name list. And the Beaverton Supportive Housing Project is scheduled to open in the second half of 2023. This new location will provide 47 units of supportive housing. We will continue to explore opportunities to increase transitional and supportive housing opportunities across Durham. Community agency street outreach teams are also being expanded to continue to improve capacity and increase housing outcomes. There are currently 2 community agency street outreach teams through Cornerstone and Caria. These teams operate Monday to Friday. Cornerstone's Bridges Street Outreach team consists of 2 staff and operates Monday to Friday. The team works in partnership with Cornerstone's retention staff to work with clients once they do secure housing and to ensure they maintain their housing. Cornerstone's Bridges Street Outreach team successfully housed 50 unsheltered clients in 2022. Caria's Street Outreach team consists of 4 staff and operates Monday to Friday. The team includes retention staff to work with clients once they are housed to maintain that housing. And Caria's Street Outreach team successfully housed 34 unsheltered clients in 2022. So the region has specialized outreach teams that are mobile across Durham. The Primary Care Outreach Program, also known as PCOP, includes 2 teams, each comprised of an advanced care paramedic and social worker providing social and primary care to people who are homeless or at risk of homelessness. The program operates 7 days a week, providing service 10 hours per day, between 10 a.m. and 6 p.m., with the flexibility to adjust their start times to meet operational needs between the hours of 7 a.m. and 8 p.m. This new hour and shift rotation launched at the end of April in 2023. The PCOP team had 2,952 client interactions in 2022. The Mental Health Outreach Program, also known as MHOP, includes 1 team consisting of 2 social workers / psychotherapists who provide outreach clinical counseling and psychotherapy services to vulnerable populations in Durham, including those who are unsheltered or underhoused and who may have mental health or addiction challenges. The MHOP team had 346 client interactions in 2022, and it is important to note that the program was not at full capacity in 2022. The Adult Protective Service Program supports vulnerable at-risk individuals with developmental disabilities to access and maintain housing through homelessness prevention support. Ongoing provincial funding has been confirmed under Support to Access Housing to expand housing and homelessness supports for individuals with developmental disabilities. The Region Street Outreach Strategy is being updated to increase the number of dedicated teams across Durham, including a regional team and partnerships with community agencies. Increasing investment in street outreach programs will ensure more appropriate coverage across Durham to support the increase in people experiencing unsheltered homelessness. Street outreach teams work to develop rapport and trust with those experiencing homelessness. They can then determine what the needs are, get them connected to supports, ensure they are on Durham's by name list, and connected to the Durham Coordinated Access System, We can assist them to meet goals and move toward housing options. The region is developing a direct delivery street outreach program, including 10 frontline regional staff and 2 supervisors to operate across Durham. Regional Council endorsed a motion at the May Committee of the Whole to create a regional street outreach team mid-year. This team is in the process of being hired and is expected to launch in the summer of 2023. Coverage will be piloted on a 24/7 schedule.
The region will be updating the coordinated access matching process to leverage case conferencing by establishing a continuum of support model for Durham's by name list and coordinated access system. This will better coordinate the pathways between engagement, street outreach, shelter, case management, and the flow between housing programs. This will clearly define how clients are supported along the continuum. This will include updating Durham's community priorities that is used to prioritize housing opportunities within the coordinated access system. Regular case conferencing will be used to support the new matching process to ensure barriers to achieve housing stability are addressed. Improving training and coordination between programs and agencies. The annual review process highlighted the need to provide mental health first aid and crisis prevention training for all frontline positions within the support system. Regional staff will begin organizing this training for fall of 2023. Regional staff will support shadowing between system sectors and programs to help build better relationship and collaboration across the support system. We will be improving strategic planning for the sector by hosting a planning day using the theory of change framework and develop a strategic plan for the homelessness in Durham. This event will include internal and external stakeholders who have an interest or a mandate to support vulnerable population. This event will be planned for fall 2023. We will be establishing a centralized phone line and email to support residents to navigate homelessness support services 7 days a week. This centralized point of contact will ensure coordinated response for all referral sources, reduce the number of touch points that residents have to make before their concern has been addressed. Developing a community resource for residences and businesses on homelessness, including things such as whom to call and what resources are available. This resource will be held on durham.ca, and flyers with QR codes will be directing them to the toolkit that will be made available. Expanding shelter capacity and location across Durham to support increasing demands. A new family shelter in Whitby is being established as Durham's first family shelter and will provide a capacity of up to 5 families. This will help create the capacity to respond to families experiencing homelessness in Durham. Continuing to support the new shelter location in Ajax and redeveloping the program model from winter warming programs to a housing-focused shelter program. Improving and expanding shelter supports for seniors experiencing homelessness through partnership with Cornerstone, Caria, and Lakeridge Health. This includes expanding the senior motel program and aftercare supports, as well as nursing, personal support workers, and a health-led case management. Exploring a potential opportunity to establish a supportive, low-barrier emergency shelter that includes holistic on-site services to better support clients with complex and concurring needs. Increasing affordability and supportive housing outcomes is important as shelter capacity expands. To prevent creating bottleneck in the shelter system, each new shelter bed will be accompanied by approximately 6 housing outflow opportunities. This ensures that there are an opportunity to turnover within the shelter system, and that will result in positive housing outcomes for the clients. Supporting staff across the system. It has been previously shared that there are ongoing challenges with the recruitment and retention of frontline staff due to limited funding for staff wage and increasing level of client needs across the support system. Frontline staff are required to respond to mental health and addiction crisis. Advanced level of training and educations are now required for these frontline roles to ensure proper support is being provided. To support staff across the sector, the region is taking steps to work with partner agencies to develop a workforce strategy. Additional training opportunities are being explored to ensure staff have the training required to support their clients. The region is exploring a hybrid model for frontline services to support the workforce demand by increasing involvement by the direct delivery of homelessness support across Durham. This report aligns with and addresses the following strategic goals and priorities set in the Durham Region Strategic Plan. Goal number 2, community vitality. To foster exceptional quality of life with services that contribute to strong neighborhoods and vibrant and diverse communities and influence our safety and well-being. Goal number 4, social investment. To ensure a range of programs, services, and supports are available and accessible to those in need and that no one is left behind. Goal number 5, service excellence. To provide exceptional value to Durham Region taxpayers through responsive, effective, and sustainable service delivery. In conclusion, Durham's homelessness support and coordinated access system will continue to experience significant challenges through the foreseeable future due to increasing rental market pressures, stagnant social assistance rates, and ongoing mental health and addiction pressures. Throughout 2023 and 2024, regional staff are focusing on system improvements to increase outflow from Durham's by name list by increasing the number of housing opportunities connected to the by name list, preventing more inflow into our by name list through homelessness prevention, and by improving support for people who are actively homeless and redeveloping Durham's outreach strategy and working on expanding housing-focused solution opportunities. A new sustained investment in homelessness programs will significantly increase the region's ability to strategically plan, strengthen, and increase the response to homelessness in Durham Region. Thank you.
Thank you very much to Sahar and Jocelyn. And I just wonder if there's any questions from any members of the committee. Okay. Councillor Jebb.
Thank you, Madam Chair, and through you, thank you very much for the presentation, and thank you very much for all the work that your teams do throughout the region. Couple brief questions. Regarding the by name list for youth, did I hear there's going to be a separate list for youth? No. Okay, out of our homeless numbers, do we know how many are youth in the region? A very rough estimate's fine.
I want to say that building on the 15 spaces that was spoken about in the presentation, that we are looking at trying to place the majority of the youth off the by name list into
Okay.
housing spaces. I'm not sure if somebody's looking right now on the by name list in the background to sort of give us a number, but it is not a significant portion of the 267 people that were, obviously every youth on the list is significant, but it's
Sure.
not a large portion of that 267 people that were reported in April.
Okay, that's fair enough. Now, regarding, sorry, next question, it might be to the Commissioner. For the new projects like the Oshawa Micro Homes project and the Beaverton Supportive Housing project, are youth entitled to be put in there or no? As tenants?
Sure.
Through the chair, no,
Okay.
no adult ages,
Just
yeah.
okay,
So is it, I'm going to look to Lisa, is it 18 plus, Lisa? Yeah,
It's usually, so looking at shelter, it's usually divided, and that limitation falls within the 18 plus, considering the justice system and some of the crossovers as well that can occur with under 18 and over 18 populations.
okay, fair enough. Thank you for that. Just trying to get my head around all these numbers.
We have 36, just to follow up, we do have 36 youth on the by name list at this time.
Okay, thanks for that. Regarding the veteran by name list, I know you briefly touched on that, and it seems like it's something that's a work in progress right now. Okay, so is that going to be a separate list for specifically for veterans in the region?
So one by name list with the ability to pull and filter for different demographics.
Okay,
So collecting all of that information in one place and coordinating it, that way somebody who would be on we wouldn't divide the list. So you might qualify for veteran housing or for supports related to veterans, but you're still on the by name list, so coordinated access would consider you as a whole, a holistic approach. And if something opens up that isn't veteran based, you would still be considered for that if your needs fit. So not dividing people out into categories that could silo them or limit their access to everything within the system.
okay, and is your team working with organizations such as the Royal Canadian Legion, as they do have veteran homeless outreach programs as well?
Absolutely.
Okay, perfect. And I'm going to direct this to the chair. If we were ever to consider, to the chair or Stella, if we were ever to consider, as we know, Beaverton Supportive Housing Project does have priorities for North Durham residents. That is unique and rare, and it's something that's, I think, new for the region. If we were ever to consider making a project such as that, because we're already thinking outside of the box, second level priority for veterans, is that something we could consider?
Commissioner?
yes, through the chair. We'd have to look at our stats and determine if that's the right process, and it does have to be an entire building, or can it be added to something else that we already have?
Sure, okay. And I know we do have our minutes of settlement. It's something we would probably have to pass at the lower level, but if we can work together on that outside of here, I would appreciate it.
And maybe I should just add that we have we're looking at 5 folks right now on
Okay.
the by name list that are veterans that we're
Okay,
working with.
so not a huge amount, but
No.
still 5 that need to
But
be
still
taken
5,
care of.
yeah.
Okay, perfect. My last question through you, Madam Chair, is moving to the priority level of North Durham, how do you manage that as we get into the Beaverton Supportive Housing specifically? How are you going to manage that? Like, I'm assuming that a lot of our homeless folk don't have any fixed addresses. Am I correct by saying that, or not correct?
That's true.
Okay.
They don't have a fixed address because they are homeless.
Yeah.
We are working, sorry, through the chair, we're working on always outreach and connection too. So if they're receiving a benefit through our Ontario Works program, then that linkage gives them a contact that we
Okay.
are able to connect with people. And through programs like the PCOP and our soon-to-be outreach teams, also connecting and staying coordinated with CARIA and Cornerstone's outreach teams and North House in the north, we are able to locate and connect to people to get them into housing options when they come up.
Okay, so specifically for Beaverton, as we're going to be opening this facility, and it looks great, by the way. There's trusses and the steel roofs going on, and it's coming together rather quickly. So how do you envision, is it envision working with, North House and organizations like that to pull from the by name list as priority levels for that facility?
Do you want to take that one?
Sure, I'll take that.
Okay.
Yes, that's right. We are going to work through, we're working currently right now with North House and a couple of other agencies who are working with those who are in a vulnerable situation. So we will pull from the buy-in list, but we're also going to look at some other opportunities. As you know, we've talked about having a certain percentage of the rooms for those who are under the developmentally disabled group as well. So we're doing some work with that as well.
Okay, perfect. Sounds like you have it under control, and that is all. Thanks again to your whole team, and that's all, Madam Chair. Thank you.
Thank you. Councillor Anderson.
Thank you, and thank you for the presentation. And I don't take this as a slight against your work or whatever you do. I appreciate that, and you're doing your best. How does this report differ from the umpteen ones that I've heard over the last 4 or 5 years?
Through,
Sure. Or do
I'll take that.
you want?
Through the chair, thank you for that question, Councillor Anderson. What's different today is we actually have seen a very large increase in our homelessness state over the last year and a half. When we used to come to council, we were at a place where our shelters weren't full. There was always room for people in all of our shelters, and those who were staying outside, we would say they're choosing to stay outside. Whereas today, there are many people who are outside who don't want to be outside, but we just don't have the space for them. And as a result of COVID, we're seeing an increase in typical families coming to us, and even people who are working who can't afford to pay their rent. So what's different today is we have funding, we have committed regional funding. We have funding from the province that is actually going to be annualized. We've never had that before. We always had to guess every year around December, what's going to happen the following year? What programs will we have to end? So that is the difference. And with this extra funding and resources, we're able to really dig in and look to adjust how we're delivering. Now we're getting into the direct delivery business, having the resources to further assess the delivery as a system manager with our partners.
Thank you for that. Through the chair, I have another question. And to follow up on what Councillor Job touched on, most homeless folks, they're not recognized unless they're collecting some kind of benefits, whether it's ODSP or whatever. And you have to have an address to do that. Correct? I thought you had to have an address to collect benefits.
through the chair, you do not have to have an address to be determined eligible for benefits. Our offices are used as access points for clients who do not have a fixed address. Additionally, we are working with clients in the community at libraries, at different access points and hubs, both in the north as well as right across Durham region, to ensure that people who are coming in and asking questions are having access to staff who are supporting them to get their ID, and to be able to build that foundation to then move forward with their next goal or action. And that could be finding stable employment. Sometimes it's maintaining and ensuring they're keeping a vehicle so that they can use their vehicle as a home base and then secure employment with their newfound ID. But we are starting at basics. Where our clients need us and where patrons and residents of Durham require supports, that's where our staff are starting and working forward with them.
Thank you. One final question.
Please.
Correct me if I'm wrong, in 2022, about 84 homeless people had found residence, correct?
Yes.
Do you know how many, what percentage that would be of homeless folks in Durham?
So we can do those percentages from the by name list. It's important to remember that the by name list is a list of people who are at point in time recognized as homeless and added to the list with their consent. So our outreach teams and community service provider outreach teams are working with people who are living outdoors and unsheltered. And many of those individuals we need to build trust with to get them to a point where they will sign consent and access the by name list. So I would say every person that we house from the by name list or across our communities or help them to stay in stable housing, those are the wins. We can do some future, as we're really pulling our data together and working on cleaning it in 2023, we can start continuing to give you more statistics on the percentages of folks that we are housing from the by name list, but I'd like you to always remember that that is a point in time piece of data from the people that we've built the trusting relationships with already, not the ones who are still in our periphery or that we're making connections and building that foundation with.
Further, Commissioner?
Yes.
So we're housing about 19 people every month.
But yes, we're housing exactly 19 people every month, but we're seeing double coming through every month as well. And that's why we're not able to reduce our homelessness numbers.
One final question through the chair. Do you find a large percentage are refusing to sign consent, or they just want to remain on the street? You know, what percentage would that be? You know, do you know?
So through the chair, we're looking at individuals who have received and still are experiencing systemic barriers and discrimination at times. Really looking for building a relationship with the individual workers they're working with PCOP staff across the system. So they're not straight out refusals. If you, through the org code report, you see that there were the majority of the people who were surveyed was a really high percentage of people who want to come indoors. Their needs sometimes preclude them from what we have to offer at this moment, fitting the requirements of their mental illness or mental health and addictions, of feeling safe, of actually moving beyond some of the discrimination and the barriers that they have faced in the past. So it is a process for each individual. But do I feel like going out? Jocelyn and I were out in downtown Oshawa this week at night with the bylaw team, and people are really responsive and open to talking about what they need and what supports are required for them. We are building that foundation now that the resources are in place in 2023. So moving forward, hopefully, we will see our unsheltered population and people in need really seeing the value and being able to trust our systems to support them safely.
Thank you, and thank you for doing that.
Any further questions? So I have a few. And it's just talking about just with the by name list, but also with the outreach teams that will be going out there. And you already answered part of this question where the by name list, if they're willing to give the information, that we will be increasing the by name list. What about the transient community that we're starting to see coming through our communities?
So homelessness is people who are unsheltered can be transient because they are looking for security and stability in their services. So if I'm feeling that I'm not receiving what I need in one place, or I am exhibiting symptoms of being extremely unwell, I will move around. We are seeing people who are transient land in different communities, sometimes from another community in Durham, and moving across Durham, seeking something different, maybe more space. And that's going to happen, but we're seeing them move across communities. When we're sitting at tables and we're meeting with other regions and municipalities who are working on homelessness, we're all seeing the same thing in that. If you are really seeing disparity in what you have and trying to make a difference in your life, sometimes you're going to move around, and actually a lot of times you're going to move around, especially if you cannot find the basic needs that are required for life in one place.
Because I'm starting to see that through, especially through Whitby, there's a lot younger individuals, and not sure if we just shared that if they're coming off somebody's couch now or if they are moving along through our communities. But even last night, downtown, I noticed that two young men who I haven't seen before, and which brings into the next part, and that is about the communication and the collaboration with one, DRPS, our bylaw, our municipalities, our BIAs as well too. I know that just recently within Whitby, and I know within Ajax as well too, that there is more presence with our DRPS on foot or on bike. Last week with our own downtown constable, the businesses highlighted where they know of the homeless within our downtown. So that's given a focus as to where we can also give that concentration. But it's that focus where we know where, but what happens next? How is this communicated, one, to the outreach team, to where does this end up going, that next level of communication, and does it just stop?
So it does not. We're always connected and working on our communities right across Durham. I think our emails and our phone numbers are out there, and we're coming back together and huddling to work on individuals and to build out plans for individuals as well, in that case coordination piece. But I think as we build this foundation forward with the resources we're seeing this year, seeing an action item on a list that many other communities have had for decades, and really for us getting a central point where there's an email address and a phone number that is one space where all of that information comes in overnight and throughout the week, and we're working from. Right now it's pooling of multiple emails and calls from numerous different touch points, which can obviously cause for a slowdown in timelines. So that communication piece is a big part of our system plan, building it forward and making sure it's in place and effective.
So, and then I have two more. So the other is about that communication and the establishment of that communication, the website, the phone number. And I know that you have worked together with our staff at the town of Whitby. And we actually have a the community supports webpage, which homeless supports within Whitby, which brings it right back to the region of Durham. And I think that's a continuity of what can be brought out to everywhere. We delivered those little cards to every single business within our downtown and outside of there, and the Chamber of Commerce shared it with their businesses. I think that's become where a lot of the focus is, and like even with putting this out there in publications wherever we can possibly assist and help, it's really helped. And the church organizations as well too, who are our main supporters, from our food banks to our brown lunch bags. I think that education piece, while they are volunteers who are trying to serve the community, I think we can help to give them education as well. Even last night I was with the Knights of Columbus, and they're asking what can they do? How much more can they do? It's that education and that communication piece that I'm happy to help to push forward, and especially for all our levels of municipalities here. The last question that I have, and you talked about it, is a strategic planning session. I talked in our debrief yesterday about this report, like with the meeting for today. I think it'd be very helpful if all of Health and Social Services members actually participated in that, because we only can know what's moving forward while we're sitting around that table and understand what your struggles are as well too. And I think this would be a very helpful session that all of us can be a part of as well.
Yes.
Okay. Thank you very much. And I think we're going to move on to the next presentation.
Thank you.
Thank you.
I'm going to call upon Laura McDermott to give introduction to the next two presentations. Good morning.
June is Seniors Month in Ontario, and it's a month to recognize and celebrate the lives, the achievements, and the hard work of seniors in making our communities, our province, and our country what they are today. And because this month is focusing on seniors, we wanted to share a couple of initiatives with you that are underway in our long-term care homes that are designed to support our residents and their caregivers. So for our first presentation, we recognize that the transition to long-term care is very stressful for a new resident, but it's also stressful for the caregiver, often a spouse or partner who has spent most of their lives with that person. They often experience a sense of relief that their loved one is safely under our care, but also a sense of loneliness, grief, and loss of purpose. So as one means to address the stress of caregivers and to give them some understanding of how we can work more effectively as partners in care, our social workers developed a caregiver transition program. So I'm going to turn things over to two of our social workers, both from Hillsdale Estates, Erica Gilbert and Serene Suratharan, who will share information about this initiative.
Good morning, Chair Roy and members of the Health and Social Services Committee. My name is Erica Gilbert, and I'm a social worker at Hillsdale Estates, and I've been in the role since April 2020. And my social worker colleague, Shireen Surendran, has been at Hillsdale Estates since August 2021. Thank you for the opportunity today for us to share a presentation. Today, we're going to present on a new and collaborative program created through the partnership with Family Services Department and our long-term care social worker teams in our 4 long-term care homes. The past 3 years have been an incredibly trying time for older adults and for caregivers, with significant stressors related to health, well-being, healthcare system navigation, access to resources, and transitions to long-term care. In our social work roles, there's been a particular recognition of the hardships, adversities, trauma, and difficulties faced by newly admitted long-term care residents and their caregivers. For example, there are significant elements of loss, including loss of connection to community, friends, and family, loss of independence, loss of health, loss of home, and much more, and accompanying feelings of grief related to these losses that are embedded within long-term care transitions. Additionally, navigating the discombobulated healthcare system is a feat that not many are prepared to undergo. And beyond some of these current challenges, most people in their life don't say, I can't wait for it's my turn to move into long-term care. So already, long-term care transitions can be a very fragile and sensitive time for many. But to do so during one of the most precarious times in human history has been quite the undertaking for many of these folks. As a result, we envision the creation and implementation of programming to help address the needs related to long-term care transitional stress, challenges, and trauma. When we look at in the context of long-term care, when we look at the scope of a social work role, it has a particular focus on enhancing the psychosocial well-being of both residents and their caregivers. Core tasks of the role include comprehensive psychosocial assessments, interventions like case management, supportive counseling, psychoeducation. We do consultation within and between care teams in the home. We do support with advocacy initiatives, including advocating for resources as well as meaningful change. System navigation, we do help caregivers with. Recently, we've been able to start facilitating in-house support groups. We help caregivers with referrals to internal and external resources, liaising with community supports. The Alzheimer's Society of Durham is a big one for us, and then participating on internal and divisional projects and committees. But what Shireen and I, as well as our social worker colleagues, have observed within our roles is a particular need for caregivers to be provided with ongoing education and support at the time of admission. even though they're provided with compassionate support through the admissions teams in our homes, as well as the resident home area care team members. There's so much for them to learn and process over the course of the first few weeks and months of their transition, and without the intentional opportunity to process this, it has really had impacts on having supportive and successful transitions into long-term care. And it's also, my apologies. When we look closer at the long-term care caregiver transition itself, the caregiving journey does not end when somebody moves into long-term care. The specific activities of the caregiver might change, so they're really tasked with giving us, transferring over to us the hands-on care, but neither the importance nor the value of the caregiver ends at this point. The changes embedded within this transition to long-term care can induce a range of emotions in caregivers, including guilt, loss and grief, anxiety, powerlessness, sadness, but also a sense of relief and happiness and comfort. What is familiar to us is what is comfortable, and when caregivers go through a long-term care transition, they experience unfamiliarity and therefore significant discomfort, uncertainty, and nervousness during this time. Moreover, the COVID-19 pandemic and its related complications and stressors have not been favorable towards our long-term care residents and caregivers, and these groups have had to be even more resilient during this time. So as we continue to honor the importance of caregivers of residents in long-term care, and specifically these residents' journeys, efforts to support the wellness of these caregivers, so i.e. care for the caregiver, is also of importance. It's also imperative to recognize that long-term care caregivers, they're not only tasked with adjusting to the long-term care environment themselves, but also with providing significant support to the resident at this time. So they're trying to support themselves as well as somebody else, which is a really tall task. This pandemic has visibly highlighted the integral role that caregivers have in supporting residents' biological, psychological, social, emotional, cultural, spiritual health and well-being. And we know that the care for the caregiver for this reason is very, very important. However, the long-term care social worker scope is limited to supporting caregivers with issues related to their current caregiving journey within the home, if you can remember those core tasks we talked about in a few slides. However, caregiver health and well-being might be impacted by factors that fall outside of this scope, including historical experiences of historical trauma and childhood abuse in relation to the caregiver, in relation to the resident rather, workplace stress, family dynamics, financial stress, physical and mental illnesses, and so on. And unfortunately, our scope can't touch on all those elements that might be impacting the caregiver's journey in all of these areas. But caregivers deserve to have these experiences acknowledged and supported, and this is where the partnership with Family Services Department really blossomed from, because their scope can help caregivers explore these important areas of their life. So as we recognize the undeniable value of the caregiving role, as well as the complexity, difficulty, and burden that this role can have, we wanted to create programming with the Family Services Department to support caregivers, especially at the start of their long-term care journey. When we look at the partnership a little bit more in depth, through collaborating with the Family Services Department, we were able to create a two-part program. We developed the content for these sessions throughout 2022, and we started facilitating this program as of January of this year. The first part is facilitated by the long-term care social workers and involves hosting a monthly caregiver orientation seminar. It's really meant to help explain the context of long-term care, what we do and we do not do, helping to debunk some of these myths and help form realistic expectations of the environment, let them know about the supports that are available, as well as ways that they can communicate within the home. And the second part of this program is facilitated by a family services counselor and involves a quarterly mental health seminar that is tailored to giving mental health support to caregivers and actually includes experiential learning components. Later in this presentation, we're going to discuss more specific content embedded in each of these programs, but both of these programs are currently being offered via video conference format to align with pandemic restrictions, but thankfully they're starting to change, so we can perhaps look at this in the future, but as well as allow as many caregivers as possible to join, especially those that are out of town or those that just can't come into long-term care at this time. And when we were developing these programs, the goals that we identified include empowering caregivers, enhancing distress tolerance and their coping skills, increasing their mental health, improving their understanding of the long-term care environment, cultivating realistic expectations, and hopefully helping to reduce some caregiver complaints and concerns. And as we were looking at the operational benefits, we identified providing support to a large number of caregivers at once, providing structured, standardized, and streamlined psychoeducation across their 4 homes, helping the caregivers across Durham Region directly access the Family Services Department, and hopefully increasing referrals for their department, providing proactive mental health support for caregivers and being less reactive and less crisis-based in our work that we do, and really fostering a meaningful collaboration between the Long-Term Care Division and the Family Services Department.
So to prepare for this program content, we had asked a number of caregivers, residents, and staff currently in our long-term care homes about their experiences and what they wish they knew when initially transitioning into long-term care. So based on the information that we collected, we gathered topics to discuss in hopes that we can aid caregivers in their own journey into long-term care, or at least give some food for thought so that they can discuss more in depth with their home's care team or home social workers. To start off, we reviewed the context of long-term care in terms of the regulations. So the Fixing Long-Term Care Act of 2021 actually has over 380 regulations that that long-term care homes operate within. So we kind of outline a little bit of the regulations, the processes that long-term cares follow in order to protect, provide appropriate care, and improve the quality of care for Ontario's residents of long-term care. We also reviewed the Ontario Residents' Bill of Rights, which provide access for residents to receive safe, consistent, and high-quality resident care in their long-term care settings. We go over the fundamental principle of what long-term care is, and we really talk about the home's philosophy. So when we talk about care provided in the home, we define it from a supportive, palliative, and curative framework. So we provide person-centered and resident-centered approaches, meaning we have a very specific focus on inviting, accommodating, and respecting residents' personal wishes, preferences, needs, and desires in healthcare and their life decisions. We review what the care team involves. So does it involve physiotherapists, allied health, social work, nursing? All of the care team members' roles are reviewed. And we also talk about communication pathways. So who do you contact if you have a concern, if you have a question about your care needs, if you have a question about your care plan? So we review the roles of the registered nurse, the nurse manager on the floor, for example, how you can go to the social worker for system navigation within the home, and even how to contact the senior management in order to address their needs. And we also definitely talk about the escalation process that's available in every long-term care home, so that any comments, concerns, or questions can be addressed as soon as possible. We go over a section called Frequently Asked Questions, and these questions were developed from the feedback received from current long-term care residents, caregivers, and staff. So we talk about, what is a care plan? What does my care plan include? We talk about the clinical team's assessment and in conjunction with the residents' needs and preferences. We cover aspects of care related to medicine, nursing, personal support, mental health, nutrition, recreation, social, palliative, restorative, and religious and spiritual care. We talk about what happens if we have to make a change on our care plan, or if the care plan isn't been as effective as when it was initially set out. We also talk about the difference between assistive devices versus restraints. We talk about behaviors and emphasize that all behaviors have meaning, and if we have a care team that's dedicated to this, we can figure out what an appropriate response would be. We talk about the criteria set out for what residents can receive when partaking in the physiotherapy program. We talk about recreational programming, what that looks like in each home, and we really try and emphasize what the caregiving journey is like. And as Erica mentioned, the caregiving journey, it doesn't end when you come into long-term care. It might shift the way that caregivers are caregiving, because now they're working within a team approach. And that transition to long-term care, it can be very challenging, not only for residents, but also for the caregivers. Right, the hands-on care is taken away from and taken over by the home staff, and as a result, caregivers might experience a range of emotions, right? Whether that is a sense of relief or anxiety, powerlessness, comfort, guilt, grief. So in handing over that practical work to us, their emotions might have a different experience, and that's where social workers come in to try and support them through this journey. The transition can be quite a trying time as routines change for both the resident and the caregivers. And because of that, what is familiar to us may no longer be familiar. And so that discomfort is something that the social workers help try work through within each home. We talk a lot about self-care as well. We provide resources on books, on community resources, internal resources, on how we can practice self-care and how we can work through that range of emotion that we're experiencing when initially transitioning into long-term care. The book, What Now, is a really great book. It covers topics about the different aspects of our emotional journey, strategies on how to manage them effectively, and also talks about a bit of misconceptions about long-term care home, as well as how to recognize and respond to your grief during this time. So this webinar that we created goes in conjunction with the presentation created by Family Services Department, and that is a single session facilitated by a mental health counselor from Durham Region's Family Services Department. They provide education, support, and experiential learning to help long-term care caregivers manage their mental health, loss, grief, anxiety, depression, workplace stress, caregiver stress, and more. So it includes psychoeducation, it includes psychosocial support, and that component of experiential learning. And this will be provided once, I think we've done it twice so far, and it is a trial basis, the first time we're doing it, so that caregivers can have their needs addressed, not only within their role as caregiver with a long-term care home, but all the other stressors as well. In terms of future goals, so we, as Erica mentioned, we just started this webinar and this collaboration January of 2023. We've been doing it once every month for the first 6 months. So next week, we will complete our final session in June. And then at that point, we will take a break and just assess what the feedback is. We do provide evaluation forms after every seminar so we can collect the feedback and figure out how we can improve it if we need to, and just provide an overview of what this program is and how we can better improve it. We would hopefully like to offer in-person sessions depending on our COVID-19 restrictions. And we're also thinking about how to develop this information into our admission packages so that this information can be reached out to more caregivers. We so far have received lots of great feedback on this process. And so caregivers have commented in the evaluation in the evaluation forms that they felt the information was relevant to their current needs. They felt that it was helpful and valuable to attend. So we are hoping that we'll continue to have this program in collaboration with the Family Services Department. Thank you so much.
Thank you, Erica and sharing. Is there any questions? I don't see any. Thank you very much.
Thank you so much.
And Laura, next.
A familiar quote to everyone is that illness certainty and life is death. Death is a difficult subject for us. Residents coming into long-term care are typically moving into their last home. So providing the highest quality of life and making the palliative and end-of-life journey as comfortable as possible for our residents and families is a responsibility we take very seriously. For our second presentation, I'm pleased to introduce Stephanie Burkus, who's our nurse practitioner, and Heather Toll, who's a registered dietitian, both from Hillsdale Terraces, who are here to talk to you about the palliation program that's being rolled out across our division.
Good morning.
Good morning. Okay. For our slides to turn up there. All right, awesome. Okay, so thank you, Laura. Thank you, Chair Roy, and members of the Health and Social Services Committee for having us today. As Laura said, my name is Stephanie Burkus. I'm a nurse practitioner at Hillsdale Terraces, here with my colleague Heather Toll, a registered dietitian. And today we plan to provide you with more information about the complex needs of our residents and how we've made enhancements to our palliative and end-of-life care program in our long-term care homes. It is our goal to meet the individual needs of residents, but also improve what we have seen to be a growing need within our population.
So to start, we'd just like to take some time to go over the differences between palliative care and end-of-life care and highlight why palliative care is so important. So when we're speaking about palliative care, we're talking about a specialized medical care that's often provided when people are living with a serious illness, what we would term a life-limiting illness. At this point, we've moved on more from a curative approach, moving into more comfort measures, focusing on quality of life. This might include life closure activities or other psychosocial supports that are needed. And it's important to note that palliative care can be provided over a long period of time. This can be provided over weeks, if not months or longer. It follows someone through their diagnosis of their more terminal illness, through the trajectory of the disease as they transition more towards end of life. So when we're referring to end of life, we're referring to those final days, those final hours of life where we're providing more bedside support, where someone may be more unresponsive. We're focusing more on that symptom management and physical component, as well as providing our psychosocial supports at the bedside. So looking at access to palliative care in general, historically in long-term care, we've done a really good job at focusing on the end-of-life care component. We've continued to build on our access and improve our services within palliative care. If we're looking at access to palliative care in Canada in general, typically those that have a cancer diagnosis are most likely to receive palliative care. Stephanie will cover in a few slides in this in more detail, but most likely this is because cancer, when someone's diagnosed with cancer, they receive treatments, and then if those treatments do progress to a point where they're non-curative, we then would move to more towards a quality of life or comfort approach, which would be providing them with palliative care. Unfortunately, those who are over the age of 85 and or living with a diagnosis of dementia tend to be least likely to receive a palliative care service, just if we look at the statistics in general in Canada. That's important to note because our residents that are being admitted into long-term care are much more medically complex, much more frail, and we're having to deal with the progression of advanced disease at that time. So I'll pass it off to Stephanie to discuss that in more detail.
So in Canada, the average age of long-term care is 83. So in terms of complexity, we've seen a big change in our residents over the last 10 years. Just at Hillsdale Terraces specifically, over the last 3 years, we've seen a decline in length of stay by 100 days every year since 2019. So what that tells us is our residents that are being admitted are much more medically complex. They're much more advanced in their disease by the time they reach us. As you can see from the graph, percentage of care needs within our homes are drastically changing. We have very few residents that are low care needs, and most of our residents require total physical care as well as advanced medical care. As you can see there, a huge change in our cognitively impaired population, where 3/4 of our residents have that percentage, have that cognitive impairment diagnosis. So this tells us twofold. So we're doing a good job of keeping our seniors in the community for a longer period of time, but by the time they reach us in a long-term care home, they're quite advanced in both their disease and their frailty, and more progressive and higher care needs. So as Heather had mentioned, when we're looking at someone's disease trajectory, often when people think about dying, they might associate with something like a cancer death. So that is the green line on the graph. However, in long-term care, we're seeing mostly either medically complex deaths or advanced stage dementia. So someone with a medically complex death would be something like heart failure, lung failure. So what we see with that is someone who has that diagnosis has a lot of ups and downs. So they'll have hospitalization, which is the dip down in the graph, then a bit more of a recovery. They'll return to us, perhaps another hospitalization, exacerbation in their condition. And someone with advanced dementia is already quite frail and just progressively getting more frail until something like eating and drinking ceases. So the important point to understand about these illnesses is that they require many different discussions, interventions over time with each decline. The prognosis is different for each case. So even though we'll have 2 different residents with heart failure, their prognosis is different, the progression through illness is different. And in each case, we'll have different symptoms, a lot more of those close calls and recoveries, and that requires a lot more family support and a lot more education.
So our divisional long-term care homes have been working really hard at expanding our palliative care programs that we offer. We're also guided by our regulations. So historically in the Long-Term Care Act, there has been indication that we need to offer a palliative care program. Most recently, with the changes to the Fixing Long-Term Care Act, they've added a bit more detail about the requirements for within the Act for the palliative care program. So we just wanted to highlight a few of those for you today. One of which being that we need to provide an explanation of the palliative care options. So that would be indicating what services and supports we have available to provide. And then they also highlight that palliative care, it's important to focus on symptom management, but it's not the only aspect of care, that we do need to include areas for quality of life improvement as well as psychosocial supports. So we would just like to highlight some of the program enhancements that we've made. We've looked at a number of different areas, including assessment, communication, and collaboration within our programs. So we've standardized our assessment tools and our communication tools to try to ensure that all of our team members are aware of where someone falls in that disease trajectory as best as possible, and so that when we are communicating with each other, we're on the same page. We've also enhanced our interdisciplinary approach to our assessments so that we're providing a more holistic approach to care, not necessarily piecemeal care, making sure we're doing it at the same time so that we're all aware of what's happening and we're all able to identify those care needs. We've looked at standardizing our medication orders, so using best practices, specifically as someone transitions towards end of life, to ensure that we're providing good symptom relief. And then again, as a starting point, that can be adjusted from there, but we've looked at a standardized process. One of the areas of communication we felt was really important was early identification of a resident's health status decline, because if we can identify that decline early, we can have these conversations earlier, we can educate earlier, and we can provide those supports earlier. So we've really focused on that early identification component. We've also enhanced our care conference structure, which is more of a team-based meeting where we meet with residents and families and we talk about goals of care and we talk about wishes. We've enhanced that structure and we've enhanced the number of allied health and medical team members that have been able to attend. As for collaboration, we've looked at building sustainable partnerships. So we focused on our access to hospice volunteers as well as our grief and bereavement services. We've looked at early education, as mentioned, and trying to collaborate with families and residents on these decision-making processes, as well as establishing their goals of care whenever possible. We focused on supporting our frontline staff, so ensuring that our direct care staff and our allied health have the knowledge and capacity to provide good palliative and end-of-life care. Some examples would include some education on best practices for symptom management, as well as helping them have difficult conversations, because we know talking about dying is not an easy task, so trying to provide that additional support. We've also added an additional person to our team, so a dedicated palliative care program lead for all of the homes to help us better assess and coordinate our services.
So through some of these enhancements, we've seen some really great positive outcomes. So we've been trying to avoid emergency room transfers with expected health decline. So an example of that would be at end stage of dementia, we start to see the eating and drinking starts to cease. So if we've educated family and staff that this resident is approaching end of life, then we'll avoid an emergency room transfer for something like dehydration. We've improved symptom management for our medically complex deaths. So again, that's someone in something like heart failure. They may feel lots of shortness of breath at end of life. And previously, we've had to send them to the hospital to get symptom relief for that, but we've improved our symptom management to be able to keep them within the home with their shortness of breath managed. With our increase in volunteer support, we've made really great connections with the Victoria Order of Nurses. So if we have a resident who is approaching end of life, then we will send a referral. If there isn't too many family members around, they can send in volunteers to be with the resident. We feel that we've improved the experience of family at the bedside at end of life. We've improved in our cots and chairs that we provide at the bedside. We have a cart we put at the bedside with food and drink, books, music, and things like that, so that the family does not have to leave the bedside at end of life. And then, of course, our improved communication throughout the disease process to ensure that family and the resident are well aware of things, the whole team is involved, and give them the support they need to transition towards end of life. So our final statistic there, with our stats, we feel we've been able to provide end-of-life care within the home for 86% of our residents within the last 18 months. So why is this important? We're never going to get to 100%. There's going to be some residents that die in hospital. But what we wanted to emphasize that is that research has shown that given the choice, the majority of Canadians would prefer to die in their home versus a hospital. And dying within an emergency room or a busy medical unit is not ideal. And this is why we feel our initiatives are so important. Our residents and families continue to voice that a comfortable, dignified death in a setting where there is comfort, familiarity, and trust is ultimately the goal. So we will just continue to try and get this number up as close to 100 as we can.
So we continue to build on our services in general. Obviously, we strive for service excellence when we're providing palliative and end-of-life care. So some of the areas we're going to continue to work on is increasing those opportunities for frontline staff to have access to education. So trying to build their capacity so that when we're providing support at the bedside, we have multitude of experts available. We want to continue to incorporate those goals of care conversations as early in the admission process as possible. So as mentioned by Stephanie, most of our residents coming in are very medically complex. They may come in very advanced in their disease process. So trying to be sensitive, but also having those honest conversations about where they're at in their disease trajectory gives them a better understanding of what they would like to see happen, or a time frame in a sense, so that we can establish those goals of care and those wishes early, so that allows our team to try to meet those as early as possible. We also want to try to encourage an upward trend in a number of statistics. Palliative care is difficult to manage, difficult to assess from a quantitative perspective, but we want to look at trying to ensure that the deaths are occurring within our home whenever possible, assuming that supports the resident wishes versus dying in the hospital. We'd like to see palliative care being offered within the last 6 months of life, again, whenever possible, and continuing to have increased opportunities for those goal-based discussions to occur with the team as well as the residents and the family.
All right, so thank you so much for your attention today and the opportunity to share with you our program. Our goal is always to provide our residents with the best supportive care through their life, but also through their death.
Thank you very much, Stephanie and Heather. Is there any questions from members of the committee? I'm not seeing any, but I just want to ask with relation to, so the VON who does work with Durham Hospice, with the proposal of the hospices Oak Ridges, but now that Clarington and Whitby will be having hospices, hopefully in the near future, how do you see that relationship between the services you're providing while the opportunity could be bring a client to the hospice versus keeping them in the long-term care home? Has there been a discussion?
So I think the admission process to long-term care would be different from an admission process to a hospice center. There's always that opportunity if someone wishes to move out of the long-term care home. There is a process in place for that occurring. Our goal as a division would be to be able to provide those hospice services in-house, so there wouldn't necessarily be that need for the person to leave, as they're provided with the hospice and palliative care within the home that they live.
Yeah.
We do have a connection with the palliative pain and symptom management nurse who comes and does consults within our home to help us just determine if there's any cases that are challenging or giving us advice. And then we also work with the Victoria Order nurses for their volunteer capacity at this point. So I don't think there's been any further discussion. I can defer to Laura or Stella if you want. No. Okay. Yeah.
I appreciate the answer, and I do understand, especially with long-term care, because essentially that is the client's home now, and to go into another place, which, while it might be a nice place, their place of what they have become familiar with is a long-term care facility. My mother passed away 2 years ago. It was a long-term care facility, and it was the staff and the establishment that was just astounding, just with the support, one, that they gave to us as a family, but two, after she had passed, it was a family around, and it was the staff who were part of the family. So I thank you for what you do and for the continuous work and for your presentation this morning. And to our last presentation, Dr. Kyle, do you want to present, or can the chief present himself? Good morning.
Good morning, Madam Chair, and welcome members of Health and Social Service Committee, regional staff, and guests. I wanted to provide a brief update on the first 4 months of action or activity within paramedic services this year to provide some context of sort of what has been happening within the municipality. So with respects to call volumes, if I look at our code 1 through 4 and 8 responses, you'll see that we're trending on a bit of an upward trend. Our code 1s and 2s have always been low. 3, 4s, and 8s are the driving factor within the municipality. We're currently at, as of the end of April, 48,819 calls for service within the municipality, which is slightly higher than the previous year. But we're still able to manage that call volume right now. And that's primarily because we're actually seeing a little bit of a reduction in our offload delay. So I've presented the offload delay numbers, our 90th percentiles at Lakeridge Health Ajax Pickering, as well as Lakeridge Health Oshawa. And you'll see that Lakeridge Health Oshawa has had a huge improvement. My last report actually was showing an hour and 5 minutes from previously, and at the end of 22, we were up over 4 hours at that facility. So we are seeing a dramatic improvement in that, and that's having a real impact on our ability to service calls within the municipality. As well, you can see Lakeridge Health Ajax Pickering, we're being pretty consistent. We had a slight upward tick in the most recent month, but there was some challenges at the facility. They're doing a little bit of renovations in the department, and that's had a little bit of an impact on our ability to flow patients through that area. But that's a really positive change. Our Seton Paramedic Response Station, well, that's a bit of another story. I'm working closely with our friends in Works, and they're doing a fabulous job to sort of, I guess, battle on behalf of the region, because we're running into sort of hiccup after hiccup with respects to this station. I had anticipated we were going to be in on the fall of this year. That was the original plan based on the forecast documents we had received from the original builder through the RFP process. But as you can see, I took this photo. I went out with my drone a couple weeks ago and took this photo, and there lies the station. So it doesn't even have walls as of that point. I believe there are walls now. The steel is back up. But we're having some real challenges with the build of this station. And like I said, the rest of the team at the municipality is doing a fantastic job to try to get some answers with respects to what is the delay and how can we mitigate some of those challenges related to the actual build. Because we just, there's no way we're going to be in it by the fall. And quite honestly, I'm anticipating now, we're hoping for early summer of next year at this rate based on how things are going. Also want to thank Director McIntosh and her team for providing a little bit of an update on the PCOP side from social services, because I wanted to take an opportunity to provide a little bit of an update from the primary care outreach program on the medical side. So as everybody's aware, the team consists of an advanced care paramedic and a social worker, and they're focusing on primary outreach and service navigations to our vulnerable populations. Most of our work right now is taking place in Oshawa and Ajax, but we do provide service throughout the entire municipality. The team uses a rapid response vehicle, so they're driving around in a Tahoe to the neighborhoods throughout the municipality, and you were already outlined when the services are now provided, and that service provision is a nice enhancement. The goals of the PCOP obviously are to address the health and social services needs of the hard-to-reach populations with complex needs. Our focus on the medical side is address the urgent health needs and support individuals in crisis. We provide some supports for if they have any physical, like wound care, and we provide some basic support on mental health or substance issues, but those are obviously navigated best by our social services partners there. So in addition to that, the PCOP also assists with that service navigation. We support transition to hopefully more stable housing, and we have seen some positive impact with respects to that. And the nice thing is we improved our coordination between health and social services to these individuals. The biggest thing that was already identified is it's really important to continue to build on that trust relationship, and the teams have done a great job of developing that and continuing on with that spec. As far as what the actual services are, this isn't really new, but what I did want to highlight in there is the area in yellow that has been an advancement on the medical services side. So we've had a big advancement with our wound care, and in addition to that, we've had an advancement in antipsychotic injections. So that's a big help, because now we can essentially bring the medications right to the individuals versus counting on the individuals to stay on a regimen to ensure that they're getting their medications, because those medications, if you're not aware, are very, I'm going to use the term time sensitive to put it in the simplest of terms. It's important they stay on the regimen to ensure they get the best activity and half-life and effectiveness out of those medications. We work with Dr. Moran and Mission United, so they helped establish, support to our unsheltered population and added to the list of medications. So we do IV antibiotics, started that in late of 22, and we've identified a couple, Anseth, vancomycin as an example. The antipsychotic injections are Q14 to 28 days, and we added those in 2023, so that's a new addition for this year, and just included the ones that we're currently given, risperidone and a few others. And as well, we've added oral antibiotics for the treatments of cellulitis, which is another challenge we deal with that population. A little bit of the PCOP stats. Now, this is specifically related to the medical stuff, so I want to be clear that there's a delineation between the work the social services team are doing and our work, so this is specifically that. So ironically, you will see, the stats between October 1st and December 31st of 22, 18 visits. What that means is we document a visit when one of those individuals comes to us. So that's not when we reach out to them, so this is above and beyond than what I would call the normal sort of work performed by the team. During that time frame, they only came to see us on 18 occasions. We did perform 5 wellness checks, 2 pregnancy urine tests, and 8 urine drug screens as well. And then in addition, we changed that into January 1st to March 31st of this year. You'll see there's a big uptake. We have 58 visits, 19 wellness checks, 8 wound. We did an influenza vaccination, a COVID swab, pregnancy test, multiple urine tests, some antipsychotic injections, naloxone kits, and things like that. So we have had a big uptake on that. What I do want to present to you as well on the next slide, and if you happen to have a queasy stomach, I mean, some people may be offended. That's my little disclaimer on the photo. But I want to show you a bit of a success story related to this actual team and the medical side. So this is an individual that came in basically complaining of issues with their legs. And as you can see from the essential wounds on their legs, they needed some appropriate treatment. They had a dramatic skin infection. The PCOP team cultured the area to make sure we get the appropriate medication and basically obtained fresh clothing and individuals for or clothing for the individual and provided that to them and got them to the hub so they could have a shower. This was on April 27th, so this is how the individual presented at that time. On May 3rd, after starting to go through this treatment with our team, they were, adherent with the medication, completed their dose. The PCOP had sprayed the patient's wounds with iodine, allowed them to soak for a period of time, ensured that the patient showered appropriately. The right leg was painted with an iodine solution and wrapped with Bactogras, 6-inch cling and tubular dressing, and they followed up again in a couple of days. And just within a couple of days, you can see how dramatic the improvement was with respects to that. That's a huge improvement and a huge benefit for this individual to be able to. I think that's a great success story. That's something that's, unfortunately kind of in your face, but it does show the value of this team and the work they are doing out there. And I'm happy to support, this team and that sort of stuff, and very proud of the work they're doing. With respects to our future growth related specifically on the PCOP side, well, as was already identified, the biggest draw on the PCOP side and the greatest need we're seeing by this client population is essentially that for social services. But the medical side is still valuable to them. Things they do could benefit from are transportation services, additional supplies such as bathroom tissue, blankets, bottled water, clothing, those sorts of things. The stuff that many of us just take for granted that they don't have. So expanding the reach of the program will be able to support even more vulnerable populations within the lower tiers, and hopefully get out there to expand this program and deal with any of the areas as it becomes expansive. And you know, Chair Roy, as you already identified, this isn't identified or consolidated now in Oshawa, Ajax. You identified some folks in Whitby, and these services will be beneficial to them as well. So that's where I'd like to see this go in the future as well. And again, we've had great support from this committee as well as council on that sort of information. Last but not least, I just wanted to provide a quick update on the opioid situation. My peers from health had provided a brief update on May 4th, and they were asked about some information specifically related to numbers. So I just wanted to provide some numbers for context on that. So in 2012, you'll see the hospitalizations from opioid overdose was 15 per 100,000 within Durham residents. A slight uptick as of 2021 to 18 per 100,000. And just as an update, Durham is still kind of well below what is the provincial rate related to that. So we are fortunate that way, but it's something we're cautious of, and we continue to monitor closely to ensure that we're providing the supports as necessary for that area as well. So that's a quick update on the paramedic services. I wanted to be quick and concise for you folks and wanted to make sure you got the information, and happy to answer any questions you may have for me.
Thank you very much, Chief. Councillor Jubb.
Thank you, Madam Chair. Again, through you to the Chief. Thanks very much, Chief, for the presentation. A couple questions. I was in the back room. I do apologize. The Seton EMS station. I heard it's rather delayed. Can we just clarify on the reasoning on that?
Yes, thanks. Through the chair. So it's primarily construction delays, quite honest. We've been given every rationale, I'm going to use that word, as to why it's not happening, such as staffing challenges, supply challenges, those sorts of things. But I struggle with some of that when I see some of our neighboring areas having good success, shall we say, with their build. So, but again, the team at Works is doing a fabulous job putting appropriate pressure on the builders related to these things, and we are seeing movement, and we're taking the appropriate steps to manage that.
Okay, and did I hear it was, projected to be open this fall, but it's now summer? Did I hear that right?
That's correct. We had anticipated substantial completion by the fall. Really, by the time you commission everything, realistically, we may not have been in the fall because there are sometimes challenges with that. But we were cautiously optimistic that we could have made the fall. We're not going to make that for sure. We're realistically, like I said, I'm hoping for the summer now, so we can start commissioning by spring and then be in it by the summer. Okay, perfect. New paramedics that was approved in budget 23. Where do we sit with that on progress? Yes, and through the chair, so we've completed all our hiring on that. We were not successful in getting enough ACPs for the open vacancies. That being said, I've been working with the legal team right now because, as you do recall, ACP training was approved in the budget as well. And we've now worked with our local base hospital to have our staff evaluated to see who will be eligible to go for the training. We have a list now from the base hospital and who will be able to go from the training. And our folks at legal are reviewing the contract with Durham College right now. So we've got our numbers. We have the additional trucks on board. We put the 2 trucks on in April during the daytime, and our next 2 trucks, I believe, are going to be starting July 17th. We had a little bit of an issue getting the actual vehicles in hand. As everybody knows, there are supply chain issues with vehicles. So we're just waiting for the vehicles to be in hand so we can ensure the staff are going to be on them. Okay, perfect. Seemed like you were very well prepared for that question. Next one I have, the dreaded 2 words, Code Zero. I did hear in the back as well that offload delays are improving. Great news across the board. Where do we sit with Code Zeros specifically for the region? Yes, and through the chair. So to be honest, we've had a code capacity. Recently, we have not had a code critical for some time now. So we're seeing, again, a positive improvement with respects to that. Not only the additional staffing, but on top of that, the additional pressure relief valve, shall we say, at Lake Ridge has seen a big improvement on that. Surprisingly, over the last few days, as everybody or anybody who's been outside knows, the environment is kind of terrible. Our call volume hasn't taken the impact I thought it would take related to that. People are adhering to the advice and staying indoors when possible and things like that. We have seen a little bit of an uptake during the days, but during nights our call volumes are down dramatically.
Okay, that's good news. It seems like we're generally moving in the positive direction on a lot of fronts, which is good. So thanks again. That's all, Madam Chair.
Thank you, Councillor. Any other questions? I have a couple. So with the offloads, do we have any definitive answer as to what helped this move along with the saving of the time, with the hour change?
Yeah, there's several factors that are impacting that. The hospital is starting to get a little more of a balanced health and human resources issue. They're starting to have more effective staffing, so that they're seeing that improvement, which obviously helps us. The Sit to Fit program has been instituted. That is a very small number of individuals, but at the end of the day, every individual that we don't have to deal with on our stretcher does have a positive flow-through impact. So it's just the hospital is taking a more aggressive approach to the importance of ensuring that the paramedics are back out on the road. We've been working closely, as you're probably aware, with the regional chair, CAO, and the CEO of the hospital to have meetings, and she was very supportive, as in the Lakeridge CEO, to make some of these changes and drive this initiative. It has to come from the top down, and she's been pushing that forward, and we are seeing some success. I'm quite happy with an hour. The provincial average is 30 minutes is what they recommend. I don't know that that's reasonable in today's society anymore with the complex medical needs patients are coming in with and the transfer of care and all the stuff that has to happen. But if we can remain at this number with the staffing improvements that the municipality has endorsed, I think the municipality will be in good shape.
I appreciate the answer. I was at a dinner the other night for the Durham healthcare teams, and many of the hospitalists and Dr. Tony Stone and Dr. Randy Wax were present as well too, and Matt Anderson, who's from Ontario Health Team. They spoke specifically about the offload times as well too. So even from our emerge doctors, it's important to them as well too that they look at reductions. I was quite surprised that it was part of their whole conversation for that evening as well too. With relation to the numbers where you speak about the with the naloxone, and that is, I just received from our chief of fire that with our fire, the naloxone is actually administered through some of our firefighters when they arrive to scene. Is that consistent practice across the region, or is the practice varies between municipalities?
Generally speaking, all lower tier municipalities apply the same approach. The busier stations, shall we say, so the ones in the south who have more frequent use of it are probably more comfortable with it, but all the departments have taken on that initiative and can support the naloxone pre-hospital. We do caution them because the one challenge that can happen, as you may know, when you administer naloxone is when the people wake up, they're not always very happy. So you got to be very cautious. Paramedics generally don't administer to the same volume that the fire staff do. So we often do tell them, if you can just secure the airway and ventilate the person, that's sometimes a good stopgap until the paramedics can arrive. But absolutely, if they need the naloxone, administer it. And yes, all the departments are taking that initiative on.
Okay, all right, thanks very much. And thanks for the presentation this morning and the update. I don't see any further questions. So we're going to move along to delegations. We have Lori Hagan, CEO of Charles H. Best Centre, and I believe Lori is online.
Lori, if you just want to hit your request to speak button.
Wonderful. Can you hear me?
Yes, we can. Thank you.
Good morning, Lori.
Good morning, everyone. Okay, so first of all, thank you. Thank you for this morning's presentations. Enjoyed all of them and appreciate the information sharing. Thank you, Chair Roy, for having us today and esteemed members of committee. I'd like to start just by acknowledging that we have been awarded a Durham Region Community Investment Grant in fiscal year 2022 that will be applied to our Building on the Best capital expansion campaign. So the purpose of today's delegation is really to provide background information to anyone on committee or anyone joining us today who's not aware of the center, our role in serving the residents of Durham Region. And also to ask quite explicitly for your support as we work towards meeting our expansion campaign goal. So we are the Charles H. Best Diabetes Center. We are a registered charity founded in 1989 by our wonderful Marlene Grass, who opened the center to ensure that patients and families living with type 1 receive the care that they need. So there's a lot of healthcare, frontline care that goes into living with type 1, but there's also a lot of personalization, individualized, tailored care, depending on where the patient is in their life. The other more important piece sometimes that is forgotten is just the overall support service piece. So mental health, both intervention and prevention of mental illness, common concern and need across chronic illnesses and notwithstanding type 1. We are located in North Whitby, so I wouldn't be surprised if I'm glitching for you guys a little bit. The bandwidth is not the best. We serve all of Durham. There are patients that come to us from GTA that have met us sort of as a resident of Durham and then maybe moved beyond. And so we continue to care for anyone that needs us. Uniquely, we do provide an urgent care response, if you will. So we have a clinical educator who is on call 24/7, 365 days a year. So we're playing our part in the health ecosystem, in working in collaboration and keeping truly our patients out of hospital as best we can. We do have collaborations with the Ministry of Health, who supports us. The Home and Community Care Branch does support our operational funds somewhat, working closely with hospitals who are referring any type 1 patients directly to us, local diabetes doctors and beyond, and of course, primary care physicians and primary care clinics. Next slide. So if you don't know what type 1 is, it is the type of diabetes that is less common. So 95% of people with diabetes actually have type 2, very different presentation. Type 1 is an autoimmune disease where the pancreas cells do not work, so your body does not produce insulin, meaning that you have to provide yourself with insulin, otherwise called exogenous insulin. So you're injecting insulin into your body multiple times a day or by insulin pump. And if that does not happen in a routine that's providing good self-management, absolutely chronic complications and perhaps even death can occur. It is not preventable. You didn't do it to yourself. There is no cure, and it can strike at any age. So although often our focus is on children and families at the Best Center, we do have a very large cohort of adult patients and senior patients. 75% of people who live with type 1 do acquire or learn of their chronic illness in childhood. Next slide. So I'm here because we're growing, the region is growing. I don't need to review the numbers likely for any of you. We are ultimately trying to keep pace. Certainly our mission is to keep children, youth, adults living with type 1 diabetes healthy until a cure is found. So we are not on the cure end of things. So we are continuing to provide hands-on care with our nurses, our dietitians, our social workers, our affiliated physicians, pediatricians, etc. So as referrals come our way, it's our intention and our goal to see those people as soon as possible. We're still seeing new pediatric diagnoses within 24 hours, but I will be completely honest in saying that with our caseload being what it is, adults who are being referred to us who currently already live with type 1, those initial visits are taking longer. We expect really that our base, what we would call an active caseload, will likely double by the end of 2027 to about 5,000 patients. And when we think about who it is we serve the patient who's sort of the center, but everybody in their community, our caregivers, whether it be work colleagues, grandparents, school, daycare. So we are a part of that education for everybody that is involved. Next slide. So hopefully some of you have been to the Best Center. You know how beautiful we are. We're on the heritage estate of the Dryden Farm. And so the house as it exists now is just simply not, there's simply not enough space for private counseling rooms. And we use private rooms for families and certainly for, individual patients. So our hope is to double patient capacity, and in doing that, we would double the space. First floor accessibility is the goal, and will be achieved for phase 1 of the expansion. And what you don't see in the vision there is there's a behind sort of the new build of the black and glass area. That will be a new build. Right behind that will be a large education space, which will be both used for families, healthcare providers, and the ability to revenue generate for the center as well. So this is where we are. We embarked officially on the campaign in 2019, and we did work through COVID and had great success throughout, but we are still not there yet. So we've raised in total from the beginning, we're at about 3 million, just shy of 3 million. As I said, we are thankful to the region for the infrastructure grant, which at that time was 7.5%, was projected to be about 340. I imagine that will likely need to change, being the environment that we're in. The municipalities as a whole are collectively pledged and donated 550,000. And then we've got great community support, corporate just over 1, individual community events, etc., at about 1 million. And then Best Center staff and board at 135. Probably the most important piece of this slide is the sort of the slice of the pie that resides in the government support, which is only at 29%. And our hope is to get that increased significantly as we have been lobbying and engaging with the province. And then, of course, the hope is that the federal government will follow suit. So we're at a split of 29 and 71%. Next slide. So that is the ask. And again, I'm being completely transparent. We have, for the last 3 years, presented to pre-budget committee to the province of Ontario in the hopes that we would have their support in capital funds to the tune of 1.75 million is what we're asking. So information sharing with you today in the hopes that many of you, in terms of dignitaries, will know who we are and can sort of support and endorse our request to the province. And I would appreciate that very much. We do have a short video just to wrap us up. Hopefully it will work.
My name is Alina and I'm a BEST patient.
We were on holiday at Punta Cana and Alina's blood sugars went up, and I called them from there, and Sandy guided us all the way back to Canada to so that she was safe.
I know it was extremely emotional for both of us. We were extremely nervous. The staff, they were all very helpful and walked us through all the steps.
The Best Center has changed our life drastically because the guidance that we received from them was amazing and continue to receive from them.
Building on the best will save lives.
Like mine.
So with that, I thank you for your attention, and I'm happy to take any questions.
Thank you very much, Lori. Is there any questions? So Lori, I have a couple of questions, and I think one of the things, and having been involved with Charles H. Best, is that the sharing that the need for type 1 diabetes, and especially the video you just showed of the little girl, is that the option is death if the treatment is not in place.
Yeah. Yeah, so, just from a strictly like a advocacy and sort of communication standpoint, that is, it's hard to say, but the truth of the matter is if we don't educate and treat and support anyone who has a new diagnosis of type 1, that they really are going to have a very hard time just sort of day to day. But if they don't get access to the insulin they need, the glucometers they need, things that are tangibly needed to live, then ultimately, death is true reality.
Yeah, thanks, Lori. The regional chair is not present today. He's on municipal business. Has there been a request for a letter of support from him? I'm assuming that's what you're asking for. You're asking for a letter of support.
Yeah, indeed. And we would appreciate that as a collective for sure. Also hoping that, truly we've had great support from the mayors across the region, a collective letter or understanding from both mayors and members of council would be appreciated.
Okay. In his absence, I think that, well, the committee would be very supportive. I think that in courtesy for the chair, that we'll take this as a takeaway, and that at the council meeting that will bring forward a motion and asking that the chair and mayors will sign a letter in support for you. Is that appropriate?
Appreciate that. Thank you.
Yeah, no problem. And I'll get the clerk to do that as a takeaway as well, too. Thank you, Lori, and have a great day, and we'll be talking soon, I'm sure.
Thanks. Take care, everyone. Bye-bye.
So moving forward, we're moving on to our correspondence. Can I have a mover of our correspondence? Councillor Jubb, Councillor Anderson. Is there any polls? So while within the correspondence, there are 2 items that I did pull, but I'm not going to ask them to be pulled for this present time, but I would hope that our committee has read through that correspondence. I think it's very vital and important for our moving forward in the number of issues, especially around the opioid crisis that we will be discussing as well too. Is there any opposed? Hearing none, seeing none. Moving along for reports with health, there are no reports. We have no correspondence in social services. And I have 2 reports. Can I have a mover on the reports? Councillor Anderson, Councillor Dies. Is there any polls? Not even on the policy paper? I'm going to pull the policy paper if you wouldn't mind. On the remainder item, all in favor or no, any opposed? Seeing none. I think it's important that with the policy paper that has been presented, and Alison Burgess is here. This came out of a Health and Social Services, one of our meetings, and there are a number of areas within the recommendations of where concentration will be given through this report. One is our advocacy positions. And I don't know, Alison, do you just want to kind of do a very highlight Cole's Notes version just to, especially around the advocacy positions of what we're going to be doing first and foremost?
Sure. Thank you, Chair Roy. So within the report, we took away Chair Henry's request from Health and Social Services Committee in April to ask the federal government to declare a national emergency, and expanded that based on all of the consultation and conversation that happens through our staff, through all the reports that you've seen come forward to this committee, through our conversations with our community partners, Lakeridge Health, DRPS, and others, and came back with this set of advocacy positions to share. The advocacy positions generally fall within 3 themes. First is homelessness, looking at asking the federal government to declare a homelessness national emergency, asking to provide flexible funding to create more deeply affordable and supportive housing, looking at increasing the wages for homelessness support sector workers, reducing poverty by increasing Ontario Works income levels, and increasing the portable housing benefit. Then went through a series of advocacy asks related to mental health and addictions, and again, through Dr. Kyle's support, have worked with Lakeridge Health to refine these. Support to the healthcare sector in Durham Region by supporting the Ontario Shores Empath model, approving the Lakeridge Health planning grant, looking at embedding best practices and best practice approaches to mental health and addictions at all Durham hospitals, increasing the stabilization beds for mental health and addiction specifically, and increasing the frontline support, such as those you heard about today, the primary care outreach program and the mental health outreach program. And second to that, AMO has a comprehensive report where they have 15 action items, and we're recommending that we endorse AMO's integrated approach to mental health and addictions. And then the third pillar was around victimization and criminal behavior, looking at ensuring that those who are incarcerated have access to mental health and addictions programming so that they are well prepared to integrate into the community upon release. fully implementing the community reintegration program across all correctional facilities. This is a provincial program that is in place in 25 locations across the province and looking to ensure that it's integrated in all correctional facilities in Ontario. Implementing and addressing bail reform for repeat offenders, and then strengthening penalties for assaults on transit workers, because we are seeing that increase across our community. And so with those three pillars and that set of advocacy actions, looking at developing a short-term advocacy strategy where we use our government relations consultant, Strategy Corps, to socialize these ideas with the provincial and federal government through their contacts. We create and request direct meetings, and then ending out with an advocacy day that aligns with our AMO conference in late August. Perhaps I'll leave it there, Chair Roy, and answer any questions you might have.
I appreciate that. Any questions? I want to, I made comment earlier just about being in attendance to the Durham Health team and having with the OHT, that Matt Anderson was actually present there. And one of the questions that ended up being asked by one of the family doctors was around the mental health and their ability to not be able to support mental health, because that's not an area that they are experts in, and they feel that they're not getting the supports either. But when the question was asked about looking at ways that we could bring programs into place within the community, such as the Empath program, it was rather interesting. The answer that was given is that if it was an organized path in terms of the outcome is, for instance, we know that with hip surgeries, we know that one going in, the outcome for the coming out. So it's a positive path, so it creates a positive. But he says that there's more of an issue where there's a negative outcome where you just don't know what that outcome is, which is predominantly what the Empath program is presenting. We have this program that we're looking at putting in place, but we're not quite sure what the outcome is going to be, but we're hoping that it could be this. And that's where the buy-in and support is not necessarily coming into place. Meanwhile, we sat in here as mayors with the MPPs, and we heard the feedback to say, well, the Empath program is not a program that is operated here in the province of Ontario, but yet when we attended to the AMO Homeless Symposium, the question was asked from a representative from London, and London has this program in place. It's, again, and I know you don't have the answers, Allison, but this is the frustration that we do actually have in place, and we do have partners around the community who do want to support to be able to, one, do family care, but the mental health component of it, they can't give that care, but they just don't have access as to where they could send somebody that is in crisis. I think that's an area that we can be reaching out to as well, too.
So appreciate that context, and I won't comment on the details about the family physicians and how that network works, but will say that yes, we do understand that there is support for this Empath model, and that's part of this advocacy strategy, I think, is making sure that that's brought to light and that everyone is aware of what approaches have been used and that there is support for this approach to come to Durham Region.
Okay, and then lastly, just talking about healthcare as a whole and within the whole presentation for this, we already heard from Charles H. Best, and we know that there are other resources out there that give that community care of health, and we're also not hearing fully what the requirements are from our healthcare supports, even such as Durham Hospice or Community Care Durham. I know that within all these organizations, they're also an entity that gives support in. Are we collecting also as knowing that we have a number as to where a hospital needs to be built within Durham Region, but do we also know with the home care services and the services in the community as to what is required out there as the community grows and the needs grow?
I'm not sure I have the answer to that. I think it's a really good question, and I'll maybe just see if Commissioner Danis Papakonstantino or Dr. Kyle want to add to that. I do know there is work happening through our community safety and wellbeing tables, workshops looking at the full spectrum of care and including those community agencies. There was a workshop held that actually provided a lot of the inputs that went into this policy paper, so perhaps more work needs to be done there to map the entire system and the needs of the healthcare sector, but I don't have a specific answer for you to speak to their needs.
Thanks, Allison. Dr. Kyle, do you have?
excuse me. We've tried to map out in our previous report at the last committee meeting the range of services available, both with respect to opioids, but as well as mental health services. So I really don't have much to add to kind of what's the landscape out there. I'm not sure I'm answering your question, but we did try to paint the picture of what's out there. And as Allison said, we did work with the hospital sector in refining what's before you today in terms of advocacy. So I really don't have much more to add to what we've already done.
No, and I appreciate it, Dr. Kyle, because I don't think that there is 100% an answer that can be had. I think it's one that when all the parties are at the table, that the discussion needs to take place, and this policy paper is creating that discussion. We need to be talking about this, and we need to be outlining what we are doing, one as government locally, to give representation to our community, so that there is an understanding out there. Because I'm finding that in any type of conversation I have, whether it's with the provincial government or even out within the community, it's not understood what situation we are actually in. And it's helpful now to actually put pen to paper and to show, like, here we are.
What I would say is one of the elements in the advocacy paper speaks to populating some of those planning tables at the central and at the regional level with, among other things, representation from boards of health, including regional municipalities, so they can add their voices, and those voices can be considered for planning coordination purposes. So we've tried to address it that way. Thanks.
Okay. Thank you, Dr. Kyle. Councillor Crawford.
Thank you, Madam Chair. I have a question around the consumption and treatment centers. Is it appropriate to ask here now? Or did we pass it? I'm sorry if I missed it.
We did pass it, so once we've moved through this report, I'll just bring it back. And
Okay, thank you.
You can ask the question. So seeing no other questions, I think that just to point out that this policy paper that's here in front of us, I think this is a key point within the region for just talking as a whole. Councillor Anderson commented earlier that we have had all these papers, we have had all these discussions and feedback on how we can work through this. I think that this is now compiling it, bringing it all together, and now being a voice as to what our needs are and to have that collective approach. So it's the action behind the words that is now coming into place. And I think this has been very well done and appreciate it very much. And any opposed to, we already did the vote on that. Oh, we didn't? Any opposed? Seeing none, hearing none. I'm going to actually, no advisory committee resolutions, no confidential matters. So Councillor Crawford, do you want to, under other business, ask your question?
Thank you. Have we always had the ability to apply for, I guess it's called safe consumption and treatment sites? Is this fairly new?
Dr. Kyle.
So thanks for the question. I would say no, they're not new, but when the current government was elected in 2018, the application guidelines were changed, and the model changed from strictly consumption sites to include a kind of treatment component. So it had a more holistic feel to it. The other thing that changed, as I understand it, and we've tried to outline that in our information report, is the process that is required both to get funding and to be deemed a Ministry of Health approved CTS, as well as what is required to get a federal exemption from the federal Controlled Drugs and Substances Act. The rules that are in place were developed in 2018. There does appear to be a limited number of CTS sites in Ontario. I think the cap is 21. I think it may be lower than that. So just because you apply for a CTS application doesn't mean that it will automatically be approved and you'll get provincial funding to operate such a CTS site.
So the funding is through the province and not through Durham Region?
The funding is through the Ministry of Health. You're applying to be an approved CTS site, and you're applying to receive provincial funding through the CTS program.
Okay, thank you.
No problem.
Nothing further? Any other questions under the business? Seeing none, our date of our next meeting is September 7th, and I need a motion for adjournment. Councillor Anderson, Councillor Jubb, any opposed? Have a great day, everyone, and thank you.